you can create a perforation, you have bleeding in the pericardium, or you lose equipment. So perforation is a major complication and frequently leads to tamponade and potentially hypotension. There are two types of classifications. Traditionally, everyone has been using the Ellis classification, which is for severity, with 3 being the larger ones. But now, as shown on the CTO ARC document just published, what is also very important is to know the location of the perforation. If this is a large vessel perforation, distal vessel, or collateral vessel perforation. And the reason for that is that management is different. So for large vessel perforation, you need a covered stent. For distal vessel perforations, usually it's fat or coil embolization, and the same for perforation of septal or non-septal collaterals. Actually, the majority of perforations, that's a review from our lab, was actually main vessel or large vessel perforations, but there is still a significant proportion of small vessel perforations. So starting with the large vessel perforation, when does it happen? It can happen, as you see in the previous case, that of course went very smoothly, that atherectomy is one of the potential causes of large vessel perforation, but other causes are use of oversized balloons or stents, especially if there is balloon rupture. Balloon rupture can actually cause perforation in the setting of severe calcification, and sometimes exit of wire or microcatheters. And how do you treat this? And we like to call this, to divide this into 2 categories. One is the so-called universal algorithm, which are steps you should do regardless of the type of perforation and the location of perforation. And the second part is to actually specifically treat the cause of the perforation. If it's a large vessel, usually it's a covered stent. Distal vessel, usually it's embolization. And then we do not reverse the anticoagulation until after we actually remove the equipment from the vessel. And rarely, if everything else fails, then the patient might need to go for emergency cardiac surgery. So what do we do first? The very first step, any perforation, get a balloon up, either proximal or other perforation site, and stop the bleeding. That minimizes the risk of tamponade, makes everything much easier to handle. We give some intravenous fluids and vasopressors if needed. Norepinephrine is the most common one. If the patient develops hypotension, then we have to do pericardiocentesis, and actually quite often we'll take the blood and give it back through a peripheral vein. This is an example of pulsus paradoxus that can happen. Of course, the difference in pressure with inspiration does not only happen with tamponade, but even with deep breathing. But this is an example of the patient with tamponade after perforation. And then pericardiocentesis can actually be facilitated because if you have PCI, you have contrast, contrast may actually go into the pericardial space, and now you have a target for your needle to get in and advance a drainage catheter. Lastly, we do call the surgeons. They are not needed in the vast majority of patients, but if they're needed, it's good to have the heads up early so they can prepare the cath lab if something is needed. The next step is to treat the cause. So going to large vessel perforation, covered stent is the answer. At least in the US, there are 2 covered stents. The PK papyrus is used more often because it's much more deliverable, single stent versus 2 stents. And it can be delivered with 2 ways. One is with a single guide. If you have a 7 or 8 French guide, you can use the same guide to have a blocking balloon up and deliver the covered stent. But if you don't, then you may have to use the so-called ping pong technique, in which you use one guide to have a balloon to block the bleeding into the pericardium, and a second guide to deliver the covered stent. So how this is done with a single guide, first step is the balloon, then you have a second wire, you deflate the balloon for a few seconds and then advance the guide wire through that area of the perforation, and then you reinflate the balloon. So while you're preparing your covered stent, you are not having bleeding into the pericardium. And then you deflate the balloon once the covered stent is ready, advance the covered stent, deploy it across the lesion, and now we have sealing of the perforation. If you cannot deliver the covered stent through the same guide catheter, what you can do is get a second guide catheter. So you have the balloon up from the initial guide catheter, you pull the guide catheter back, so you open up the ostium of the vessel, and then you get a second guide catheter, same as before, deflate the balloon, advance the guide wire, reinflate the balloon if needed, deliver the covered stent, remove the first balloon, deploy the covered stent, and treat the perforation. Now, when it comes to the distal vessel perforation, there it's different. Although sometimes you can use a covered stent, if it's a very small branch, you cannot get selectively into it. but most of the time you do use something to embolize the vessel. We traditionally use coils and fat, but many things have been used, such as wire fragments, thrombin, or clotted blood. There are many different things that can be used to embolization. The most common cause for this distal vessel perforation is advancing a guide wire. And that is why whenever you cross a CTO, for example, you always replace your polymer jacket or your stiff guide wire with a soft wire, so there is less risk of actually going through. And then how do you treat it? You decide what is your form of embolization. Fat is universally available. It can be delivered through any microcatheter. The downside is you don't see it very well, and you have little control about where the fat lands. The coils are obviously more expensive, and they need sometimes a larger microcatheter, but you can very controlled deploy them, and you know exactly where they are before you deploy them. And how do you do this? This is done using most commonly the so-called block and deliver technique, which is very similar to what you've seen for large vessel perforations. So here is a distal vessel perforation. Balloon is up to minimize the bleeding. And then you deflate the balloon to advance a second guide wire. And over the second guide wire, you advance a microcatheter. And if you have 0.014 inch coils available in your lab, then this can be done through even a 6 French catheter. So the microcatheter is advanced, and then you can visualize by injecting contrast through the microcatheter, and you can deliver your coils or fat or whatever embolic material you want to use in that area, and then confirm that you have sealed the perforation while maintaining hemostasis by having the proximal balloon inflated. So in this way, you minimize the pericardial effusion. A common problem, which is very common, especially early when you do this, is that the fat is hard to insert into a microcatheter because the fat tends to float and fall out. So the way to do this, you turn the microcatheter upside down. You can use a small introducer needle to push it a little further in if needed, and then you push it with 1 or 2 cc's of normal saline down to the vessel. As I mentioned before, if it's a small vessel perf, you can put a cover stand across the origin and seal it off. But again, embolization is what happens most of the time. When it comes to CTO and collateral perforation, if it's a septal perforation, most of the time you don't have to do anything. However, sometimes you may get hemodynamic compromise, and then you may need to embolize or coil that septal perforation. And when you have an epicardial perforation, sometimes you may have to embolize from both sides of the perforation with either coils or thrombin or fat to make sure there is no bleeding from the back end of the perforation. There's an example of thrombin. Again, this is perforation of the epicardial collateral. That is why epicardials should be done later on in your learning curve, because they do have high risk of complications. So to summarize, having a perforation can be a major complication, but having a systematic approach where you do step by step, inflate the balloon first, take care of the hemodynamics, and then treat the cause either with a cover stand or embolization, that can really come a long way to provide you a successful outcome. So once again, thank you very much for the invitation, and welcome any questions.
Thank you, Dr. Manas, for an excellent presentation and very good cartoons explaining everything very clearly. Those are taken from your book of CTO intervention?
Yes, these are all from the manual and the manual of PCI and manual of CTO PCI.
Thank you very much. And do you remember any case where you had to send the patient for surgery for the sake of perforation?
We did have actually a case in which it was a complex perforation that we could not deliver any cover stand. We tried, it was extremely calcified, couldn't deliver a cover stand, and eventually after like 3 or 4 hours of trying, we ended up sending to surgery. So it's rare, but I mean, it can definitely happen, and it's good to be prepared for that.
Dr. Ajay?
You know, for us, it's been quite a while since we sent somebody to the OR for surgery, but I will tell you that sometimes if you don't drain the pericardium quickly and you get clot in the pericardium, they may have to go to surgery, not to fix the coronary, but to deal with this pericardium and clot in there and that sort of thing. And that's why it's so important, as was mentioned in the prior session, to, you know, call for help, get the drain in and seal the perforation, because that can be a problem. The other thing too, that, you know, Manas's talk is fantastic. You can't cover everything, but what often happens after a perforation is patients will get pericarditis afterwards. You have to deal with that. And these people need to be monitored very closely in the CCU or the ICU after this occurs.
Okay.
Dr. Manas. Hello, Dr. Manas. Dr. Rawat here. Yeah.
Fine.
Yeah, you said one of the causes is the over-dilatation or high pressure. Nowadays, people are using the opine balloon, the size opine balloon, and go to 30-40 pressures, and not much perforations are reported with the opine balloon. That is what they claim. What do you think this paradox due to?
That's an excellent point. Actually, we do not have that balloon in the United States yet. But I know, speaking to several of the European operators, this balloon is much safer actually because it's designed to go at these high pressures. What happens in the cases, at least in our institutions, is that you use the regular non-compliant balloons and it's a heavily calcified lesion. So you go 25, 26, you go higher, you have higher pressures. And sometimes if there is a calcific spicule for whatever other reason, then the balloon ruptures, and that's the rupture actually creates a jet of contrast that can cause the perforation. And that's why the advice we give everyone is before you inflate at high pressure, make sure your balloon's prepared very well, because apparently if you have air in the balloon, it can make things worse and create a bigger perforation and air embolization as well.
Dr. Hasmat, what is recommended is the optimal sizing. You shouldn't oversize the balloon. If you probably quarterly undersize the balloon and go to high pressure, that's how you avoid the complications.
That's right.
The size also is bigger and you go to high pressure, that's the real trouble. So you need to keep your size under control, the diameter of the balloon, what we are talking. And if it is like 3.5, you just take a 3 OPN balloon. And even if you go to high pressures, then that you can avoid perforations. And the dual layer of the OPN balloon is what prevents from a balloon rupture and leading to perforations. That's what they mentioned. That was told by Manas. Okay. I think we need to go another interesting complication which offers many of us are dreaded, the stuck rotabar. I think we will hear about it and how to avoid it and how to manage it when we get into that by Dr. Prashad Shah.
Hello, good evening.
Yeah, go ahead. We are able to hear you and see your slides.
Yeah, okay. So, good evening, everybody. So my case here is a 75-year-old lady who's known hypertensive, had angina class 2 for about 4 months before presentation to the hospital. She also had, which progressed over class 2, class 3 over the 2 months before admission, was advised a coronary angiography, but refused at that point of time. She came into the hospital at 1 a.m. in the night with sudden onset of chest pain, sweating, and class 4 dyspnea. The patient was found to have tachycardia and respiratory rate of 28 per minute. Her SATs were 92% on room air with bilateral basal crepitations. This was her ECG on admission, which shows a right bundle with a broad QRS and ST elevation in AVR. So this echo done at that point of time on admission showed no regional wall. There was global hypokinesis with an ejection fraction of 30%. There was moderate MR and moderate pH. And the tropi increased from 318 to over 2000. The patient was diagnosed to have an acute coronary syndrome with a left ventricular failure, was stabilized with BiPAP support and diuretic infusion, was started on dual antiplatelets, low molecular weight heparins, nitrates, and statins. And then after stabilization, she was taken for an angio the next day. This is her angio. The first angio showed that the left main was calcified. There was distal left main of around 60%. And there was a critical lesion in both the ostia of the LAD as well as the LCX, which were also very calcified. The left circumflex was dominant, and there was about 60% lesion, a moderate lesion after the second large OM. This is another view of the LAD in the epicranial view. The RCA was non-dominant and normal. The syntax score was 34. A syntax score 2 with a PCI score was 43.8, and a CABG score was 33.6. In view of this, the patient was advised a coronary bypass surgery. The patient refused a coronary bypass surgery. Relatives were also not willing. After discussion, the patient was then posted for PCI after 2 days. The plan for the PCI was to use a 7F guide, plaque modification by rotablation to LCX followed by LAD, and then to use a cutting balloon or a high pressure balloon, depending upon what we found after the rotablation. The stent strategy was a 2-stent strategy upfront. Plan was to use a left main to L6 stent followed by a tap to the LAD. Optimization of the stent, the left main was very roomy, and I didn't have a 6 millimeter balloon in the lab. So plan was to use a snuggling of short balloons, 5 millimeters and 4 millimeters NC balloons if needed. Imaging was not available. So the left main was cannulated with a 7F EBU 3.5. The circumflex was wired with a double length BMW wire, and which was then exchanged to a floppy rota wire with a microcatheter. A rota link plus 1.5 millimeters was taken, and we started burning, and gradually we started used 160,000 RPMs. After the initial burr, there was around the bend. The burr just jumped after taking the burr and then stalled. We tried to, the patient then developed chest pain and developed hypotension and bradycardia. I always take a venous line, though I don't put a wire in, but it is helpful to, if I need to, I can put a temporary wire immediately. In view of the bradycardia, the temporary pacemaker was placed, inotropic support was started. Attempt was made to pass a wire by the side of the burr, but failed. Tried to rotate the burr at a higher speed, but to release the burr, but that did not release the burr. Then the guide was then deep throated, and manual traction was applied to the rotor bore, which helped to then retrieve the burr. The check shoot after the burr, after the burr was removed, check angiography showed now that there was a dissection of the left main and the circumflex ostium, and the dissection was extending into the left main. So we still had at this point of time to still do the rota to the LAD, and so the L6 was wired and was crossed with a run-through wire, and then we tried to attempt to protect it with a microcatheter initially. The LAD was wired with a whisper wire, and then was exchanged to the floppy rota wire using a microcatheter and a dock extension. And then I realized that I couldn't use a rota as well as a micro catheter in place in the 7F guide. So the L6 wire was removed. And rotablation was then performed to the LAD using the same burr, 1.5. Post rotablation, the L6 was then rewired. The LAD was then pre-dilated with a 3x12 NC balloon, and the LAD lesion opened up well. LCX was not pre-dilated to avoid further extension of the dissection. So now the patient was hemodynamically compromised. So I could not go ahead with the initial plan. So at this point of time, we had to salvage this patient. So I planned for an SKS at this point of time. The only two reasons was that the dissection was then extending right back to the ostium, and the left main was pretty roomy. So I had no the way of optimizing my stent or doing a port in the proximal part. So, and the patient was hemodynamically unstable. So a plan for an SKS, used a 3.5 by 24 millimeter stent, which was placed from the left main into the LCX, and took another 3.5 by 23 millimeter stent from the left main into the LAD. Both were placed from the body of the left main covering the dissection. And we confirmed that in through different views. And once that was confirmed, then both the stents were then deployed simultaneously, initially at 14 atmospheres. Then after deflation, I separately dilated each of these stents to 18 atmospheres. And then it was did another simultaneous balloon dilatation in the LAD and L6 to 14 atmospheres. This was because I had not pre-dilated my LCX lesion where we had done the road ablation. We had just done the burring, but we had not dilated it. So that's why I had to optimize that result. Once this was done, you can notice the visual slowing of the heart rate, the blood pressure is picked up, the chest pain was relieved. So this was the angio subsequent to the post-stent deployments. So then did kissing balloon dilatation in both the in the left main using a 4.5 by 8 millimeters balloon in both the LAD as well as the LCX stents, and they were deployed to high pressures just to optimize the results. Then I removed that balloon, and then I used a 4 millimeters by 12 millimeter NC balloon in the distal part of the LAD and LCX stents to optimize those stents. Post stent deployment, the heart rate settled, the blood pressure improved, the chest pain was relieved. And this was the angios in the two different views. This was the ECG next day, where you can see there's a visual reduction in the width of the QRS. The STs have settled, and the 2D echo on follow-up subsequently showed that there was no regional wall. The heart function had then picked up, and we had an EF of 60%. The MR had reduced, and the pulmonary arterial pressures had come down. Follow-up as recent as Jan 2021, that's about nearly 2 years, 1.5 years. The patient is doing well. There's no angina, there's no dyspnea. The patient is doing all her regular activities. So we all know that the complication of road ablation is slow flow, coronary spasms, distal embolization, coronary dissections, coronary perforations, guide wire or shaft fractures, burr entrapment, which has been reported about 0.4%. We know the two mechanisms. It could be either distal to the lesions because the Pokesis phenomenon, where there's a small burr where it is pushed, and because of the frictional heat, it advances, but it then cannot come back. In these situations, you can still rotate the burr. In the second would be where there is a entrapment in the lesion. It's a large burr where it's severely calcified, wherein you cannot rotate the burr. So how do we retrieve? We know that we can try simple manual tractions, balloon dilatation by the side, which is very difficult sometimes. You can use mother and child technique. That is, in this situation, if I would not have been able to retrieve it, then I would have to cut the rotor wire, get a guide extension, and then to pull it out. And if nothing else works, then of course surgery. After this case was done, at that point of time, I did not know about this, but there's another technique wherein you can use a double wire technique, wherein instead of using a microcatheter, you can wire both the two lesions, but you can take a rota through a guidezilla, a 7, which Dr. Sharma was also just alluding to our previous case, wherein you can use a guidezilla and a rotor ablation through that, so both the vessels are then protected. So this I didn't know at that point of time. I used a microcatheter, but there are reports where microcatheter has been used, but the risk is that the microcatheter could then fracture. The rotor can go through that. The other technique is wherein you can use a ping pong technique, as you can say. In this case, you can use two guides, wherein you can protect one of the vessels with a guide extension and do a rotor ablation with the other guide. So these are the two things that we could have tried, but of course, this can help us later on. Thank you so much.
Thank you, Dr. Prasad Shah, for showing an excellent case. And luckily, patient did well. But as you have told later, that there are methods to avoid getting the wire out. And generally, when you have a proximal dissection extending into left main, it is very heroic to remove the wire straight away and go into LAD. And generally, when you are working on that, when the LAD proximally has a tight lesion, we tend to tackle that first, and probably because of sizing, you must have decided to commit into LCX, but otherwise left main to LAD, then you would have tapped to LCX. That is a regular procedures which are followed if you're not doing a DK crush. I think final result was good, but image guidance would have helped us to decide what sort of debulking technique to use it. And especially when you're doing such complicated cases, I think it's better to have image guidance. Like Ajay always says, in US, they have such sort of cases, they would have 100% imaged and did it, but the lack of facilities could have done otherwise. But when you're dealing with such complex scenarios, it's better to do the best to the patients. I think comments from Manas and Dr. Ajay.
Yeah, thank you. I think it was a phenomenal save. Oh, sorry, Ajay.
Go Manos.
Okay, thank you. So again, I think it was an excellent save. We do say that SKS is the technique we don't want to use, but the one exception is exactly the way it was used very nicely in this case. When the patient is sick and you don't have many other options and you don't want to lose any major branch, I think that's when SKS can help and provide a nice result, and as he recently showed. I must say, that was a little brave doing a rotablation in the LAD, for me at least, after having the issue on the circumflex. But again, it was a phenomenal result and excellent save, so congratulations.
Yeah, I would agree. I think the one thing, though, that I probably would have tried before, and this usually comes up in these sessions, before trying to wire with a second wire and pulling the sheath back too much, because that rota sheath just stretches, is especially in that position, if you pull the rota wire back, because the wire has a sort of weld at the end of it, it actually frequently releases the burr immediately. And then your guide doesn't have to go in as far and it comes out. So the problem is sometimes when you try that and it doesn't work, then you have to go to plan B, C, and D. But for most cases of stuck burrs, that trick will work pretty quickly.
Actually, if you see that the circ had a bend, and so I had to get the support to get that burr out.
Yeah, no, it makes sense. And I was actually surprised. I thought, initially this was a stuck burr complication, but that case could easily, because of the bend, have been a perforation complication too. So it was a tough case all around.
I think these are the cases in which proximal very tight calcific lesions, if you can do a small balloon dilatation, and IVL also could help, because the lesion was very proximal, especially when the calcification is more in the medial and more deeper planes. IVL has supposed to be some advantages. And whenever there are tortuosities like LCX and all that, it's better to avoid rotablation, because there's more chance of burr getting stuck in these tortuous lesions, especially when like LCX, when it wraps around the heart. Any comments, Dr. Hasmukh?
No, I think the great salvage he has done it. Actually, excellent result after that. I agree with Dr. Manos and Kirtane. He shouldn't have tried to do the LED rotablation. I wouldn't have tried. I would have just balloonate, cutting balloon something and try to put the stent as early as possible. And second dictum, that what you said is absolutely right. Any salvage procedure in left main dissection, the first step should be the stenting the left main to LED, because and then do whatever the tap or reverse tap, whatever you can do it around. That is the best thing, because SKS has limitation for a young elderly lady like this is all right, but SKS is on limitation for future intervention. So that is a good dictum, that left main to LED should be stented rather than SKS. But in a salvage procedure, has excellent and good job. Congratulations.
The patient's anatomy favored, because left main was very roomy. It could accommodate both stents. I think that's how in the troubles got cooperated, and finally had a very good result. And we'll go on to the next presentation, Do or Die, Race Against Time. This is from by Dr. Anuj Sharda.
Good evening, everyone. I am audible.
You're audible, but your slides not yet come. Click on that.
Are the slides there?
No, not yet. You can double click on the slides thing. It will become big.
Dr. Anuj, if you can unshare your screen once and reshare, and when you are sharing the screen, just make sure you are sharing your presentation in the Zoom. Just choose your presentation. Yes.
Yeah, we can see.
You can see your presentation now. You can do it in the presentation mode. Yes.
Good evening, everyone. First of all, my sincere thanks to Dr. Arneja sir and the organizing committee of Nagpur Live for giving me an opportunity to share my case, condition where we have stuck up, and it's a do and die situation for us, where what matters, it's the race against. A 70-year female, non-diabetic, non-hypertensive, recently thrombolized at peripheral center and referred to us in a state of persistent chest pain. She was on minimal inotrope support and she had one episode of self-limiting VTAC. ECG showed persistent ST elevation with RBB, and echo showed anterior territory hypokinetic with moderate LV dysfunction. There was no evidence of rupture and effusion, and labs are within limits, and immediately posted for CAG in view of persistent chest pain with the intention of rescue. This is the angiogram of that lady. There was a tight lesion in the mid part of the LAD and the proximal around 80% lesion, and there was another lesion in the mid of the circumflex and the non-flow limiting lesion in RCA. So it's a more or less a straightforward case as far as the rescue PCI is concerned. We planned for rescue PCI to LAD and interval to circumflex. In view of this, we went ahead with the extra backup with the radial route with the workhorse wire and dilated with 2x15 balloon. Initially, I thought there was no much thrombus, and it's turned out true for the mid part of the lesion. There was no evidence of much thrombus at the mid part of the lesion. And put a 2.5 into 23 DS at 14 atmospheric pressure. This is the result with the stents. So till now the things were going according to our protocol. So I thought it's better to take a proximal one also, because it's look 80%, but as the stent cross, I thought it would be an easy job for us. But as we have placed a balloon over there and dilated 16 at around 6 atmospheric pressure, the nightmare kicked off. There was no flow in LAD, and there was stuck up contrast in the circumflex. That means there is a no flow entirely in the left system, which lead to cascade of ventricular arrhythmia and finally cardiac standstill. So basically this is a cardiac standstill. So there was a adrenal rush all around. So it's really a situation of do and die, and it's really a time to race against time. So it's better to formulate the challenge and deal with them in the quickest possible way. So we have formulated the various challenges in a quick succession. The first and foremost the cardiac arrest. For this, our team, they have geared up and started the CPR without wasting time. And by the time high dose of adrenal and norad deployed and intubated meanwhile. The second challenge, unfortunately, the cardiac radial assembly, the radial catheter and sheath were accidentally out because of decerebrate posturing and ongoing mass of the CPR. So for me, the another challenge is to take a puncture, and this time from the femoral root, and particularly during CPR. So here, the really a value of high quality CPR matters a lot. We take the femoral side, and we are ready with the 4 challenges, because this is the time when we have to establish the flow by all means in the left system. So first, I have wired the circumflex and dotted entire length with 2x15 balloon, because that is a non-infarct related vessel. And at the same time, after that, I did the same with the same wire and same balloon. I did it for the LAD. And in view of suspicion of air embolism, we have taken advantage of force line irrigation technique also. So this is for the picture in between the CPR. The total system is knocked off. It's teaming zero flow across the left system. And this is what the result after what we did. We are able to revive the patient and establish the flow inside the system. And then just after we have revived the heart, the next haunting question in front of us, because we did already, is the brain still intact? The pupil were luckily responsive. However, for the final verdict, we have to wait and watch. Now the next challenge in front of us, there was a significant residual thrombus inside the LAD. Here we can see there is a significant residual thrombosis across the stent as well as in the proximal part of the stent. For this, we did thrombus aspiration runs, and this time with the vigorous run. We did a vigorous run of thrombus aspiration catheters, and there was no significant visible residual thrombus. And now the seventh challenge that we had to take is to tackle the proximal thrombotic lesion, which led us to this cascade of complications. So we stented with 3O into 18 mm DS balloon across this. And this is what the final result. And finally, we have achieved the TIMI-3 flow. This is really a big relief, and the nightmare was over. Not exactly. Now we have another challenge, the counseling of the kith and kin regarding the arrest and definitely the successful revascularization and CPR, and the critical condition of the patient and the bumpy road ahead. So I have very much inspired by this quotation. The finding out the exact what went wrong is the key towards preventing future debacle. So this is we introspect a case, and what went wrong in our case, it's our perspective. During balloon dilatation at osteoproximal part, that may lead to the migration of thrombus into the distal LAD and circumflex simultaneously, most probably, and this result into the sudden cessation of the flow across the whole left system. Basically, this notion is supported by the slow flow just after the dilatation, and the presence of residual thrombus in LAD. And one more thing, the one more possibility we have kept in this is the possibility of air embolism, because we find some part of air during resuscitation. So these are the challenges we have faced, and the most important challenge we have to face after the cath lab is over is the post-operative turmoil. We put the patient on ventilator support, we correct the metabolic parameter of the patients like electrolyte, acidosis part, and renal parameters. And definitely sometime because of this, there is a shock liver condition, and there was a haywire coagulation parameters. So we have to control all these parameters, and definitely the hypoxic part and the sepsis part of the patient. And she spent around 12 days in ICU with few ups and downs, and recovered well from the encephalopathy on day 8. And ambulated with support on the day 12th. And in this whole scenario, the fair LV functions, it's the biggest supporting factor for us, and which was possible just because of the timely intervention and restoration of flow. And in last, I would like to quote this quotation: "Don't dwell on what went wrong. Instead, focus on what to do next. Spend your energy on moving forward and toward finding the answer." Thank you.
Thank you, Dr. Anuj, for showing this case. The middle lesion, which you thought can be straight away done, had to become so much complicated. That's why you always see both operator and patient has to be lucky. We need to respect each lesion. And probably because you had ischemia vessel is LAD and you had some trouble in LCX, that's where I think patient behave very badly and land in trouble. And unless it is absolutely essential, that's why you don't make things complicated. So for proximal LAD, if you're thinking it was not very important, then probably if you ordered it, then it was all done with LAD lesion. But if it is important, then probably you need to proceed, plan it accordingly, and avoid such things happening. I think comments from our experts, because I see very experienced faculty available. Let us take their ideas and thoughts on managing such lesions. Dr. Manas?
Yeah, absolutely. This is obviously something that can happen in any case. So actually, phenomenal work on salvaging the case and moving forward. Now, one way to maintain the perfusion when things like this happen and the patient arrests, I don't know if it's available, but in our lab, the Luca system is available, which provides automated CPR that makes actually easier to maintain a pressure while you're waiting to restore the flow. I agree with you that radial can be a problem for support, and getting femoral is a great way to go. The other option here, if you have access to it, is to put the patient on ECMO, and then you have more capacity to do whatever it takes to get back flow without the pressure of time and the patient being arrested. But I think otherwise what you did was excellent. Maintain perfusion as much as you can, work on reestablishing coronary flow as fast as possible. This was managed extremely well.
Yeah, I agree. And just one side point that I'll mention is that I do think that there are people who, in specific cases, when the flow stops, There are people who focus that their differential is focused heavily on thrombus. There are other people who are focused on dissection, and the people who focus on thrombus always give 2B3As and medicines. The people focused on dissection are dealing with stenting and that sort of thing. And always remember that while you're doing everything fast, there's a differential diagnosis to everything, and it may be one or more of those things at the same time. The other thing, just briefly for more junior people, is that remember, if you have a very bad flow limiting dissection, sometimes even though you don't have distal flow, the only thing that will keep it open is actually to stent it. So that's not something you want to do necessarily right away, but if you can figure out that that's going on, then all these other measures that you may take may not work until you actually stent to then tack up the dissection flow.
Yeah, that's a very good point what Ajay mentioned, because otherwise, unless you do it, whatever you do, it won't come back and flows won't improve. And that's the power of stent being available. I think with this, we'll go on to the next presentation. Ajay has the last presentation because everybody will be waiting for his presentation. But we have the next presenter presenting See It and Seal It from Dr. Vivek.
Thanks for the opportunity for presenting this case. We have recently done this case in Arneja Heart Institute. So this is a 50-year-old gentleman. He has recent ACS with evolved entry-wall MI. On eco-evaluation, his EF was 40% and preserved thickness was there. So this was the angiogram. You can see that there is a dominant circuit there. Mid-LED is after the diagonal, we just small stump we can see. And osteoproximal LED has a lesion which is extending into the left knee. So there is totally occluded LED. Small stump is seen distally. So syntax score was high. PTC versus CA, which was the option. Considering the osteoproximal lesion, I think provisional stenting is the good option for going for the bifurcation stenting. And imaging is must because we have to optimize the stenting as it involves left main. So initially we considered that the provisional left main stenting was our plan. So luckily there was we easily passed this C1 wire distally, and with just 2 millimeter balloon because it was already looking thrombotic lesions. Low pressure dilatation done. And we can see distally LED, some thrombus was there, diffusely we can see. So we consider that IVUS, pre-IVUS we will do so to see the landing zone and size of the vessel and also assess the length. So went ahead with the IVUS, and this is the IVUS. You can see that there is large plaque burden is there throughout the disease segment. And we also can see that there is a patchy areas of calcium is there, and definitely at the opening of circumflex there is a large plaque burden. So we need to come into the left mid while we are stenting. So osteal stenting is not an option. So we went ahead with the plan of provisional left mid stenting. So the osteal dilatation done initially as there was heavy plaque burden was there. The rest of the segment we avoid dilatation considering slow flow might be the problem. So the 3x38 stent we have put drug-eluting stent there. So and afterward, after putting the mid-LED stent, as we know that there are different platforms are there of stents, and it will not accommodate left main size. So we have taken another stent of 4x12, which is the IVUS side showing osteal diameter around 4 millimeters. So we have taken that. After putting this 4x12, we notice that there is pinching of circumflex is there. So within 4.5 millimeter balloon, we had done for spot, and we thought that this may be the carinal shift because there was no any significant lesion at the osteal circumflex. So our plan was to do kissing balloon and assess the condition of the circumflex osteum. So the few mistakes we have done that we have not kept wire across the circumflex at that time. So this is the attempt to cross the circumflex. So after crossing the circumflex, we went ahead with the optimization of LAD, and there was a plan for kissing and then assess the circumflex ostium. But before this kissing, we found that there is severe spasm or filling defect is there into the proximal circumflex, and there is a we can see slow flow in the whole system, that LAD as well as the circumflex. Concerning dominant circumflex, the slow flow is barely tolerated by the patient. There was sudden hypotension, and now patient starts thinking, and so there are few possibilities are there, as we not dilated any part the circumflex segment. So there was severe pinching was there, but initially there was TB3 flow was there. But subsequently we found that there is severe slow flow is there. So the first possibility is spasm or significant luminal compromise that lead to this slow flow in there. Second possibility is distal embolization, thrombus may be there, and third possibility is dissection, which I think remote possibility, because we're not crossed, we have not done anything in the circumflex. On the second injection, we see that there is a dye hanging in the proximal segment, so definitely some dissection might have happened. So even with vasodilator, flow is not improving and condition is worsening. So we not got any time and patient is sinking. So we decided that immediately we will see this part where there is a dye hanging is there. So as per the plan, we have taken long stent, that is 3/30, and we planned for the doing PAD. But in this, we forget to put a balloon across in the LAD. And while deploying, we noticed that stent is too much inside the left main now. So instead of improving the patient, the condition get worse. We thought that with this long stent, I think we can improve this patient's conditions, but we can see there is no flow in the circumflex and in very sluggish flow into the LAD. So the slow flow is still there due to hypotension. There is limitation of giving vasodilator, so we have taken thrombosuction catheter, put inside, deep inside, and given nitroprusside and adenosine. But still slow flow is there. So obviously we thought that there is microvascular clogging maybe there, that might be leading to this. Thrombus may be distal to stent, that filling defect we are seeing, and third possibility is dissection. So this filling defect we initially thought is more of a thrombus like. So we checked ACT, which was optimum, and on thrombosuction there was no thrombus was we have seen, and repeated thrombosuction and vasodilators given to this same thrombosuction catheter. But filling defect was still there. Flow temporarily improved with vasodilator, and again slow flow used to go. The patient is cardiogenic shock, and what we should do next? We are in dilemma. So we thought that we should also confirm that our wire is in the true lumen. So we taken it back. We passed with another vessel, and you can see that it is a true lumen. So the thrombosuction and vasodilators are still not working. Heterogenesis now we can see more distally at its at the level of the bifurcation. So this is going more and more distally, filling defect. So we thought that the patient is slightly stable now. We will do IGOS and we'll assess this what is happening there. So we are done. This is at this bifurcation level. So we can see in the third frame there is some dissected part, and maybe intramural hematoma may be the possibility in this case. This is the part below the we have done this IGOS below this stent. So finally, we decided that we will stent it because our wire is in true lumen, and we can seal off and see what will happen. We were initially hesitant to put stent because first stent not work for us, and we had to put this stent at just the nominal pressure, and we are not expecting any dissection. So finally decided to stent this segment. So with overlapping stent we put, and with surprise, every business is gone. Flow is improved there. Now, next challenge was this stent which is come much inside the left main. So what should be done? So what we have done, we have taken out the wire in the LED and we rewired the possible through the distal strut, and we went ahead with this optimization of stent and finally kissing balloon. And now everything seems to be settled. Slow flow is not there. Patient hemodynamically improved well. So we want to see the area below this stented segment, which was normal, and we not seen any intramural hematoma or anything else, and well optimized stent we can know. By going back, this was the final result. After going back in case, I think we might have caused all the problem because of this step where we were attempting for the distal strut. Take home message is, I think complications are avoidable with meticulous step we followed. I think many complications can be avoided, and experts panel's opinions.
Dr. Hasmukh sir, you want to comment first? Muted.
Yeah. Sorry. A lot of interesting thing. The procedure was started without the wire in the circumflex first. I would have liked to put a wire in the circumflex, and I don't know, probably the way he put at the distal stent in circumflex, it could be the spiral dissection rather than anything else, which has resulted. And last he tried to get the wire through the distal strut, already has passed the things from that stent, the expression catheter and all the things, and without crushing to go to the distal strut and wasting time on that, rather than we should have finished with that, whatever he got the lumen at that time, because already the stent was expanded at that particular portion. And if you try to go to distal strut now, you will change a lot of carinae geometry and ostial circumflex, is a bad site for the wrist stenosis. A lot of things could happen, the thing. So that was not a right. I mean, I would have just finished it up, whatever not put a much effort to put a distal wire, because you already put a expanded in the left main, stent is already expanded in the left main, the circumflex stent is already expanded in left main, and now to get a distal, you have not crushed also. So a couple of mistakes you have did it, but probably it was unavoidable for you, and probably for you to start with the wire in the circumflex would have helped you a lot. And but ultimately you got a good result. Excellent, good salvage.
No, Hasmukh, actually, the problem started because there was a very significant plaque shift into the circumflex. And then we thought we'll just correct everything. This is more of a carina shift. So we'll cross over into the circumflex and do a kissing, and we'll see, because there was no lesion at the ostium of the circumflex.
Right.
But as you see, it was the recrossing into the circumflex which caused the initial dissection. Going back, we realized that our attempt to cross into the circumflex, trying for a distal strut rather than what the lumen that was available, as we saw, we tried crossing that, and possibly that caused the dissection, and then that went in spirally down, ultimately for us to then put in 2 stents and get back. So it was anterior MI patient, LED area was infarcted, left dominant circulation which got compromised. So I think here the differential was either a dissection or something going down into the circumflex. And once we realized it's a dissection, there was no option but to seal it. But going down, it did not seem a dissection until we did an OCT. That OCT confirmed that there was a flap distally, and then there we put in a second stent, and then everything was fine. We just optimized the stent that was there in the into the left main, because the patient was hypotensive. The first stent had to be put in an emergency, so we had no time to get a balloon into the LED to do a crush or a tap. But eventually we finished with all the procedures and got a good end result.
Anyway, I think there are a lot of preventable things which could have been done, and as I already told by Hasmukh, we are running behind the schedule. We'll go to Dr. Ajay's talk on management of calcification. And a lot of interest now because of more and more calcific disease and elderly patients are being tackled, and availability of the technology, newer IVL coming in, lot of interest. Let us hear to him about deep calcification lesion management. Over to you, Dr. Ajay.
Oh, great. Thanks so much for having me. It's a pleasure to participate. I'm going to show you a case and then talk about why preparation is so important. And so this is basically somebody who we took care of who actually had stents deployed in the proximal LAD with lesion preparation, actually. But unfortunately, the stent was underdeployed. And so at that point, it was tried to do rotational atherectomy through the stent to ablate it, but still unable to expand the stent, and the patient continued having symptoms. And so this is what the stent looked like. You can see it's a big LAD, and in this area here, there's just this area where the stent is just completely compressed. We tried to image it with the IVUS. The IVUS would not cross. We tried taking 2.0 balloon, would not cross. Ultimately, only a 1.25/6 balloon crossed, followed by a 1.5 balloon. And then attempts to expand it with NC quantums at high pressure and different brands as well. You see this waste and how compressed the stent is. And remember, this has already been ablated with the stent. Obviously, there are techniques to deal with this. And in this particular case, what we ended up doing is trying specialty balloons and ultimately did contrast laser. And with that, we're able to expand the stent. We were able then to deliver a stent and treat the case successfully in the end. So this is the complication. And unfortunately, this we see not infrequently. A lot of us get referrals for cases where the stent is underexpanded. Sometimes during the case, it can happen as well. And I think it's important to determine whether this is more broadly generalizable. And I would say the answer is yes.
Is a connection problem for everybody or only for me?
I think it's only for
Dr. Kirtane, I think. Dr. Kirtane.
Ajay.
Yeah.
Sorry, I lost my connection there. All right. I don't know where I lost you, but I'll start at this point. You can hear me, right?
Yeah, we can hear you.
Hello?
Yeah, we can hear you, Ajay. Go ahead.
We can see the slide and hear you, Dr. Ajay.
Okay, good. Sorry. Okay, good. So you know that these calcified lesions can make the case tougher. There's no question about that. And what ends up happening is you don't get good expansion within the calcified lesion itself. And that's because you have a tube and you're trying to expand a stent within a tube. But if you don't crack the tube, the stent is not going to expand adequately. So the other thing about calcium is that we know that it can increase your rate of repeat revascularization, but what people don't know is that it increases your risk of stent thrombosis in addition, and that's why it's really important to get a good result. So how do we treat it? There are many, many technologies out there, and I'm not going to cover them all in detail, but I'll give you some tips to try to avoid some of the issues. And we heard some of them already about prepping the balloon properly, doing good technique when you do rotational atherectomy. Even with IVL, you need to be able to deliver it, et cetera. I think the fundamental principle that people need to remember is that in order to achieve expansion, you have to get this crack. If you don't really get a crack, it's going to be very difficult to get expansion, particularly if there's circumferential calcium. If there's calcium only on one side of it, you'll expand in the other areas. So you'll still get a big lumen, but with its circumferential, you have to get a crack to be able to expand it. We don't really know which of these therapies is best, and I'll speak for a second about studies to look at that. And a lot of times what you hear is what people say. Some people say, oh, why didn't you use this for that? Or why didn't you use an OPN? Or why didn't you use IVL? We just don't know what the best strategy is. And a lot of times the angiogram can be deceiving. There are cases, I had a case Friday where it's the most calcium I've ever seen on an angiogram, literally. And actually most of the work was done by a balloon because most of the calcium was deep wall. So I think it's important to be honest and humble about these things and understand that even if you tend to like one thing better than something else, there may be other ways to do the same case. And there's also other issues such as safety of the patient and then cost as well, which factor into it. This is what IVL does and what balloons will do in general. This is sort of calcium fractures. And once you see these fractures, the stent will clearly expand. We know the data that was presented at TCT showing that this can be done pretty safely in relatively straightforward calcific lesions. Now, for other cases, like some of the ones we've seen in this segment, you can't just do IVL, you need to do atherectomy. And in the United States, we see atherectomy uses increasing, although it still remains under 5% as a whole. Now, how do we do atherectomy? What are the systems? We saw the RotaPro being demonstrated. I know it's not available in India yet. Don't worry, I personally don't think you're missing that much. We were very comfortable rotational atherectomy users. Paul Tierstein actually jokes that the only problem he has with the new system is he can't figure out how to put his foot on the table to turn the switch, because basically what they've done is they've just gotten rid of the foot pedal and put this on the switch. It's also electronic and there are other features that do make it better. But the point is, if you're comfortable using the old system, the new system honestly just adds a little bit of expense. Now, in terms of the use of rotablation, what is known though is this phenomenon of rotoregret. And so if you go into a case and you think you probably needed to use atherectomy and you didn't use it, the outcomes are worse. And so this is a study from Antonio Colombo's group showing that your procedure times were longer, your fluoro times were longer, your contrast was longer, you know it was more painful because you tried first with balloons and then you ended up going to atherectomy. So many times with atherectomy, it's one of those things, once you think it, just do it. And then you see how that case that Samin and Anu and Samin did and what ends up happening. Now, similarly, it's important to recognize that if you only have moderate calcification, there's no real difference in strategy success of a balloon versus a rota, NC balloons versus a rota. It's only when you have severe calcification where the rota strategy success is improved. And then one other point, because it did come up in the live case and we talked about it a little bit, is there really is no difference in slow flow with low speed versus high speed. But I do think that in terms of safety, the low speed can be more effective. And so that's one of the reasons why that new system is set at 155 as the default. Now, in terms of other systems we have here in the United States and now in Europe is orbital atherectomy. The advantages of it is it's electronic, and Samin spoke briefly about the fact that it's a thinner burr. But one of the important things for this issue of the hemodynamic compromise is the flow rate that goes through it is much, much more than that of the rota. And so that plus the burr size, as well as the fact that it orbits, may lead to less hemodynamic compromise. But I can tell you that at least from our experience, our use of hemodynamic support, pacemakers and the like is significantly less when we use orbital compared to when we use rota per se. Now, in terms of the studies that led to approval, Orbit 2 is the US study that led to approval, but I think a nice study to look at that was just presented at TCT is a single center experience with mixed operators from Mount Sinai, Miami. Nirav Beohar is the first author of this, a good friend and colleague. And what he showed is that basically with experience, you could actually get very, very low rates of angiographic complications with this device. And I think that's generally been the case, especially now that they have a special wire called the flex tip wire, which actually handles, frankly, almost like a workhorse wire. And so these issues of wiring with the wire in place and not having to exchange become much easier with this wire compared to other wires out there. So in this slide, I'll just sort of put this up there because I know you're not that familiar with orbital, but I would say that there are strengths and benefits of each. Rota definitely has advantages, orbital has other advantages. And so the idea for me is that if you have both, then you can actually pick and choose which one you're going to use based upon the specific case. It's also important to know, though, that either can be used in most cases of severe calcification. The one thing that we are doing with orbital is that we're running a study of orbital versus conventional non-compliant balloons, and with both an OCT endpoint as well as a clinical endpoint. And so the idea here is to say, look, we need to prepare these lesions adequately, but do you need to use atherectomy or can you use balloons? Or do we think atherectomy is superior? So this is what this study will be doing, and we're almost 3/4 of the way enrolled in the study. So just to conclude, I think it's number one important to avoid getting into that first case. Recognize calcium is more and more prevalent. Before you put the stent in, prep the lesion adequately, especially in people that are older, have more comorbidities, or have been managed medically for a long period of time. Those people often present with more severe calcification. These lesions are among the highest risk lesions we treat. short-term pain and suffering, as well as risk, not only of dissection, not only of perforation, not only of stuck devices, as we've seen in these cases, but also long-term outcomes, because these patients can come back with restenosis and other challenges. So with that, I'll conclude and certainly have time for discussion on this, but I really think that the way to avoid a complication is to prevent it from happening in the first place. And that's where the idea of lesion preparation comes in. Thanks very much.
Thank you, Ajay, for stressing the fact of bed preparation. And unless it is done well, if you put stents here, as you have shown, you'll end up with problems which are difficult to be tackled post-stenting again. Though need expertise, we have various methods to do it, but it's always better to not to get into that. You've very well presented that. Manas, you want to, any comments on that further from your side?
No, I agree that there's an excellent presentation overview of the different modalities. I guess the bottom line is for severe calcium, it's something to many people don't treat until it's too late and the complication has happened. So I like Ajay's point that you have to really take care of it at an early stage, think about it proactively, and do a good preparation of the lesion. Once the stent goes in, it's too late to take care of the problem if there's a problem.
Ajay, we wanted to understand from you, are there any particular instances where you prefer orbital atherectomy over rotational atherectomy? Osteal location, something like that?
I mean, I think it just depends. Yeah, it's just ease of use is one. You can do it all through a 6 French. I think for cases where you have larger vessels, then with one device, you can get the bigger size as well as the smaller size. And there's just a variety of ways where you can sort it out. I also think that it's all experience. You need to be good at it in order to do it well. And there are people who sort of say, oh, Rhoda has more complications or CSI has more complications. I think the complication rates can be kept very low with both, as long as you know how to do them. The one thing, though, I will say is for patients with tenuous hemodynamics, I personally prefer the orbital versus the Rhoda for the reasons I mentioned. It may be the particle size, it may be the flow rate, it may be the fact that it's smaller, but we tend to see much, much less perturbation of hemodynamics.
What is the percentage of cases in which rotational atherectomy is used compared to orbital, just for a rough idea? 50-50?
In our lab, it's almost, I'd say it's 50-50, but it depends by operator. There's some operators who are very Rhoda heavy. There are other operators who are CSI heavy. So it depends. And for us, at least, we like having both and IVL because it offers us options. But I would echo Samin's point, though, about the cost, at least in the US right now, $4,700 for the single device without a reimbursement, when before we had it, we were very comfortable treating calcified lesions. So we and others have stressed to the company, they need to do data, they need to do a study, show us that it's better than an NC balloon, for instance, because maybe certain cases,
the NC balloon would be fine. So I think that's sort of where we see it. I will say, though, in the case I showed with this underexpanded stent, it's probably better than using contrast laser, but I just don't know.
Yeah, that sort of case, we also get away by doing OPN balloon, which is much cheaper. Sometimes you get away. So what we tend to use clinically is the severest possible calciums. We tend to take IVL somewhere in between. We get away with OPN, and the mild ones, we get away with NC ones. That's some of our clinical practice, what we do now. I think, Hasmukh, you want to ask anything to Ajay?
Yeah, just one question. Depending on the type and the severity of the calcium, like a concentric, circle, eccentric, do you have the device choice between the orbital, routine atherectomy, and IVL? You have the choice means which device to select, which type of calcium. You just go with your experience and perception.
Calcified nodule, I think that would favor orbital. But as far as concentric, I think at this point, either of them could be used. And that's something we need to sort out. We need to study it to figure it out.
Okay, thank you.
Dr. Jaspal, you want to say anything before we close?
I think we have discussed it very well.
Yeah. Actually, we should congratulate you for organizing this program in these tough times. We have very fond remembrances. Before he wanted to start his center, we went somewhere, we had thoughts how to do it, and we're very happy for you. They have established a successful center in Nagpur. And for say Ajay, and Ajay must be knowing, and Manas, India is expanding into tier 2, tier 3 cities, not only the metros like Mumbai and Delhi, Calcutta, Hyderabad. A lot of good work keeps happening in other cities too. Congratulations to all of you, and for showing the good cases. We've learned a lot of things, how to tackle perforations from Dr. Manas, and how to deal with calcification with Ajay, with cases showing in between, depicting how to prevent, and we had a lot of good discussion on it. I think with this, if there are no further comments, we will close the session. Thank you, Ajay, for your time, and thank you, Manas, for your time. Just for others to remember, Dr. Ajay Kirtane, we requested to be part of our ACC 2021 conference next Saturday. He'll be talking on CHIP 10 commandments, where we'll show the importance of imaging others in the CHIP procedures. Thank you, Ajay, for your time. Thank you, Manas.
Thank you.
Thank you so much.
Thank you, Dr. Srinivas and Hasmukh for moderating this session. And my special thank to Dr. Ajay Kirtane and Dr. Manas for being with us in this conference. And it has been, this is the third session, 2 days of the meeting. It has been a very fulfilling experience. The faculty and the attendees, we have generated, amazing interaction, good exchange of scientific data. And the basic aim is, to disseminate the knowledge and expertise and the skills of our senior faculty into the younger cardiologists and all of us, and howsoever we repeat, we have repetitive conferences. Repetitive learning is a repetitive process. You catch up one point, 1 or 2 good points of a talk. I think that's good enough. So, and the virtual, nature of this meeting has actually helped us to, get, senior experts like you all here. So I thank all of you, the faculty, the attendees, my organizing team who has worked hard for this conference. It was a very fulfilling event. I thank you all, and hopefully next year we'll see you all again. Thank you once again.
Thank you, Jaspal. It was a great conference.
Thank you. Thank you very much, sir.
Thank you.
Bye. Thanks.
Bye-bye.
Wonderful. Thank you.
Thank you.